Thank you for the introduction. I want to get a kind of an idea of the audience that I'm talking to. And so Sean Keys, pediatric orthopedics in Orlando, Florida. It's good to be back in Tennessee. I missed the mountains while I was driving down from Nashville last night and actually FaceTimed my kids while I was driving down. I'm like, look, hills, it's cool. And so everybody in here, mostly primary care, right? So maybe some urgent care settings. Anybody in here from the ER? Okay, and so my talk is, so I do ped sports and trauma in Orlando, Florida. My talk is kind of my perspective to help you in the primary care, urgent care, ER setting to get patients to come and see me, and when, right? So we'll go through a fracture conference, we'll go through lots of x-rays, lots of splints, lots of repetition to kind of really drive some points home. How do you stabilize the injury? When do the injuries follow up? And we'll also go through a few common sports injuries that you guys will see. And you know, my job, and this is how I try to train residents, train fellows, train APPs is, you know, there's navigational beacons on how we practice medicine. Right? There's not one perfect avenue for the most part, especially in orthopedics. Our literature shows that. But my job is to give you the options and help you find what is easiest and best for you. So everything will always have different options. The art of medicine and the art of your patients. So the scope of this is for the urgent care, the ER, even some acute care private practice settings. So know the scope of your practice, and so identify the injury. Is this something I can safely and appropriately manage where I'm at, and am I comfortable taking care of it? Because if not, that's okay. Triage them up to the next level, whether it's the local ER, the local urgent care, local ortho urgent care. I don't know if there's very many of those around here, but it's a pretty big thing in Orlando. And then I'll give you, again, the orthopedic perspective on things. And so if you want to take pictures of this website, these are actually hyperlinks that I can't click, obviously. But they have great PDFs and videos of different splinting and casting types, what the indications are, whether it's a buccal fracture, a radius fracture, a forearm fracture, a finger fracture. Every fracture you can think of, you find that, and it will show you the splint that you need. It will also give you all the materials that you need to put on that splint, and sometimes an accompanying video of how you put on that splint. And so you can know and then go look it up and then come back and do it. And the very last link, the University of Ottawa, they do a really great job of cast removal. If you work in an urgent care or an ER, it is very rare, but once in a while, maybe once a year, you will have to take off a cast. And so you may want to refresh your memory on that, and that's a quick link to a YouTube video of how to do it. And so we're going to start with the fracture conference. And so I'll try, I'm a very fast talker, and so I have to be very conscientious to slow myself down. But I will try to speak very slowly and allow you guys to try to come up with a diagnosis, what type of immobilization, splint specifically, you would put that patient in, and when do you think they would follow up. And I have a tendency, and I feel like as we get through these, I will speed up. And so the tenets of fracture immobilization that if you know this tenet, then you can splint and immobilize anything, okay? And so if the fracture involves the joint or it's right next to the joint, just that joint needs to be immobilized, okay? So if it's a finger and it's right here, just that joint needs to be immobilized. If it's the wrist, it's just at the wrist, just the wrist needs to be immobilized. If the fracture is away from the joint, in the middle of the bone, in the shaft of the bone, the joint above and the joint below, okay? If you know those two things, you can get through just about anything that you want. And so this is a little 8-year-old boy. Dad was working out, not paying attention. Kid dropped a weight on his finger, okay? And so an injury like this on the front part of the finger, the flexor tendons are underneath there. And so typically how we would recommend this be managed is you irrigate out the wound just with some saline. Do a simple digital block if you can get the kid to tolerate it. Inspect the wound, honestly just make sure that they can flex and extend their finger, because if they can't, then they need to go to the local ER, because that'll probably need to be fixed by a hand surgeon. But if you're in an urgent care or an ER and they can flex their finger, honestly wash it out. Simple, non-absorbable sutures. Do not make this perfect or cosmetic. You'll make yourself crazy. Always use absorbable sutures. So I like Vicryl or Monocryl, because then we never have to take them out. The worst day in a pediatric orthopedic's life is when a child walks in with nylon sutures, 25 of them, in a finger, underneath the scab. That makes for really bad reviews for our office. And so please, if it's on the skin, even in adults, just use absorbable, and then nobody ever has to take them out. They'll fall off eventually. Tensile strength of Vicryl and Monocryl is gone after 2 weeks, falls out by 6 weeks. And so save everybody a headache and use absorbable sutures. I can't drive that home enough. I tell everybody, and in every presentation I give, please use absorbables. And so for this one, I would probably do 2 or 3 simple, uninterrupted Vicryl sutures, put it back together and put them into an alumifoam splint. And so this was the associated injury. I will pause for effect. And so there's a small Salter-Harris 2 fracture on the dorsal aspect base of the middle phalanx, non-displaced. And so just a simple alumifoam splint. And so if you're not familiar with these, they are money. They're awesome. There's lots of different varieties of these. And so put them in that splint. Let's go back to this. And so there we go. Tenets for follow-up. And so these are the 2 things I would tell you for follow-up of fractures. If the bone is anatomic, it's right where God put it, God built it, or it's darn close, it can follow up in a week. That's totally fine. And so you just put that in your discharge paperwork, say follow up in a week. If the bone looks like it is moved, it's not where it belongs, or it's not anatomic, follow up within a week, right? And so for us, that's in a week is 7 to 10 days. Within a week is 3 to 5 days, meaning if it was seen on Monday, it needs to be seen before Friday so that we can fix it if we need to. Most things in orthopedics are not emergencies. We've got up to 2 weeks, even in kids, to do something about it. But we do want to be timely and conscientious of what we're doing. And so that fracture is pretty much where God put it, and so it can follow up in a week. And so this is your typical young kid riding a skateboard, riding a scooter, falling off a bike, falling off a trampoline, getting double bounce, the classic foosh, falling out, stretched hand injury. And so you can see transverse fractures of the distal radius and ulna metaphysis, right? And so right next to the joint. So really just that joint needs to be immobilized. It's not exactly where it belongs, but in this age group in our world, it's fine. But for you, when you see that, it's not exactly where it belongs, should be seen within a week. These are 2 different splints you could use for that. And so those come from those website links of what you can see. And so technically the volar splint is plenty. Just that joint is fine because it's right below the joint. If you're more comfortable putting on a sugar tongue because that's how you trained or that's where you are, or regional variances or a reverse sugar tongue, that's totally fine as long as you immobilize the wrist. And so no, it wasn't anatomic, so it should be seen within a week. And so I don't know if this projects well. It looks really good down there, but I'm going to point to it. And so this is a type 1 supracondylar humerus fracture. So a little kid fell off the monkey bars, jumped off the slide, fell on their elbow, got run over by their dog. Simple elbow fracture, it's exactly where it belongs, right? So it can be seen in a week. It is right next to the joint, so just that joint needs to be immobilized. And so a simple long arm posterior splint is great for this. Tips for advice on a long arm posterior splint are if you're going to get a pressure sore, it's at the tip of the olecranon, right? And so make sure there's a little bit of extra padding there. And number 2, yeah, you do have to just immobilize the elbow, But if you stop that splint here at the wrist, within 2 days, by that evening, the hand will look like a hot dog, super swollen because the vascular flow can't go back up. And so please always just include the wrap into the hand so the hand doesn't swell, because that's what they'll complain about most. Their elbow doesn't hurt anymore, but boy, their wrist and their hand is swollen and it's so painful. And that is a driving force for parents to remove the splint. They will take it off and not put it back on. And so definitely wrap the hand anytime you put on a long arm splint. And that's what it looks like. Starts off up at the axilla. Typically you want to take it all the way down into the hand. This one's always dad's fault, typically. And so this is the kid on the trampoline with the older siblings, or the kid going down the slide with dad. Kid puts his foot out, dad mows him over, just slides right through him. And so tibia shaft fracture, it's minimally displaced. These are typically young children. It's in the middle of the bone, right? So joint above, joint below need to be immobilized. And so for this long arm or long leg posterior splint, if I was anecdotally to give a percentage of the number of pressure sores that I will see in kids with a long leg splint, it's got to be 75%. It's almost a guarantee that I know if they come into my office with a long leg splint, they're gonna have a pressure sore. And so let's be very intentional about padding the back of the heel. In a lot of training programs, we put a lot of padding underneath the foot. We walk on our feet all day. You're never going to get a pressure sore in the bottom of your foot, especially a young child. But they're going to sit with the back of their heel until they see you. And you'll ask the parents, are they complaining of any burning pain? Oh, yeah, they were for like 3 days and then it stopped. Well, yeah, because that's awesome. But so to do that, even when we cast people, we put a doubled over ABD pad right on the back of the heel, and then wrap everything over. And then warn them, if you start hearing or complaining of burning, sharp, searing pain in the back of their heel, the pressure sore is starting. And so move the pillow from the heel behind the knee so that the heel is kind of free floating. Feel free to unwrap the ACE so that the pressure goes away, because there's some pretty nasty pressure sores. As you know, those can start within 2 hours of the splint being put on. And so again, in my practice, it's got to be 75%, and we have a lot of access to care and a lot of smart people. And so how about this one? And so this was I don't remember if this was a tennis athlete or a baseball player. I think this was my baseball player. He was going to make a throw from center field to home, trying to be the star, heard a snap, sharp pain, came into the office. And so there was obviously other things going on here, but for you in the urgent care and in the ER, what you would do for this is honestly just a simple sling, a sling and swath, or if you're like a real cavalier, it's called a coaptation splint that goes from the armpit around the elbow and back on top of the shoulder. These are super painful. They just are, and there's no great way to immobilize the middle of the humerus. And so you try to get them through the first 2 weeks and they do fine, but the easiest thing for you to do, and what I tell all of my outlying community ERs when they call me with these, is just put them in a simple sling and swath, and we'll see it. It's not exactly where it belongs, so we'll see it within a week, okay? This kid actually had a bone cyst, which is why he broke, which is pretty common for humeral shaft fractures when they show up. So how about that one, right? And so if this shows up in your office, right, do not pass go, please continue on. And so this typically is managed in an ER. In ER where you have a lot of things, we'll do a attempt to close reduction. But for you guys, does it need to be reduced? No, technically it doesn't. So if you can put this kid, so the fracture is not right next to the joint, right? And so it has to be the joint above and the joint below. So for something like this, a sugar tongue splint is great. It's not right where it belongs, so it needs to be followed up within a week. And so that's the splint we typically use for that. Little kid clavicle fractures, you guys see these all the time. They're everywhere. The the figure 8 braces that pull the shoulder back, elongate the clavicle, maybe, maybe not. Those have fallen out of favor, not really used because haven't been shown to be effective. They actually increase pain, increase complications, pressure sores. So those have kind of gone away. These are very simple, just a simple sling. In the peds world, there is almost zero indication for surgery on a clavicle fracture, and you can tell them all that. And so simple sling, follow-up in a week for pretty much every clavicle fracture. And then how about this one? So this is typically like a trampoline or soccer. Get a lot of soccers with these two. And so transverse distal tibia fracture, there's a little bit of green stick bowing of the distal fibula as well. It's near the joint, and so just the joint. So you can do a simple short leg splint. You can do a simple short leg posterior. You can add stirrups on there if you're feeling fancy. But please put an ABD pad on the heel, counsel them again on the burning or the signs and symptoms of a pressure sore. And then it should follow up within a week. It's not perfect, and that's okay. As you can tell, lots of repetition, lots and lots of repetition. And so distal radius fracture, it's dorsally angulated, it's not perfect, it's right next to the joint. I like sugar tongue splints for everything in the forearm and the wrist. That's pretty much my workhorse. And so it's not perfect, so it'll follow up within a week. This one, I believe, was a little kid Segway, which are really popular in Orlando. And then once they get into like the 12-year-old age range, they like to take the Segways over ramps, which is a lot of fun for me. And so there's a little Salter-Harris 2 distal tibia fracture right next to the joint, just the joint. So a simple short leg splint, it's pretty much where it belongs. Follow up in a week. Simple supracondylar humerus fracture, a little bit crunched, a little bit of valgus angulation. On the lateral view, it's terrible lateral, but you can see the lines are all perfectly fine. And so the point for you is it's the elbow, it's right next to the joint, just that joint. So long arm posterior splint, wrap the hand. If you want to put some extra padding behind the olecranon, that's perfect, and it's pretty anatomic, so follow up in a week. Another clavicle fracture, you'll see the bump. The bump will increase for the first 2 weeks after injury. Simple slings, pretty much where it belongs. Follow up in a week. Again, so skateboard injury for this kid, distal tibia fracture. You can see a little avulsion off the medial mal. Short leg posterior splint, it's pretty much right where it belongs. Follow up in a week. Starting to see a theme? Yes. Okay, that one should go to the ER for sure. And so both bone forearm fracture does need a reduction, but for you in the urgent care, you're not just gonna send them out with like a floppy wrist, right? And so you don't have to do a whole lot. So sugar tongue splint right where they're at, let it set, and that should go straight to the ER. Sometimes he's a walk into your office. That's always a joy. And so a little green stick fracture of the distal radial shaft. It's not right next to the joint, it's a little bit of a way. So again, forearm fractures, wrist fractures, sugar tongue is my workhorse. It should follow up in a week. These ones are troublemakers. And so this is the little 3 to 5-year-old got crunched doing something. And you look at the x-ray, you're like, oh, it's not too bad. But you look at their arm and it's like this, right? And so that's a plastic deformity of the forearm. And so from an orthopedic perspective, that's a problem because, everything in kids, we always tell them, kids are like salamanders. They can grow anything back and they'll be fine. Bones can be overlapped and they'll regrow in a year and nothing ever happened. This one won't. This one will grow in that direction. And so for you, sugar tongue splint, just like we've been talking about, but for me, this needs surgery because we have to unbend the bone bone, which requires a significant amount of slow force, like trying to unmold hard Play-Doh, to straighten out the arm so that their arm will grow straight, because it will not, it'll grow crooked. But for you, sugar tongue splint. How about this? So this is your teenage boy, probably a lineman, overweight, comes in, walks like this. May or may not have been complaining of hip pain for weeks, foot's with an external foot progression angle when they walk. And if you look at the hip, it is not normal, right? So this is your slipped capital femoral epiphysis, right? And so if they came walking in, that's a good thing. That means it's a stable-ish injury, but it does need to follow up like this week because it needs surgery immediately. But if they can't walk, that needs to go to the ER. Like if they can't put weight on it, they need to go straight to the ER because it needs surgery now. The challenge with these things is there's not great management from an orthopedic perspective to undo the problem that's already there. We can stabilize it, we can keep it from progressing. There are surgeries that we can do to make the hip look normal, but there's a high incidence of long-term complications in these kids. So these are really, really bad problems. On exam, they may not even present, so a lot of these will come to the private practice office just complaining of, honestly, knee pain. And the reason they're complaining of knee pain is because the obturator nerve runs right past the hip, terminates at the knee, and they're like, man, the inside of my knee is just killing me when I walk. And so always when you're doing a knee exam, start at the hip. And when you flex their hip up, they'll get that obligate external rotation where there is zero internal rotation. Their hip just comes up and flares out. That should clue you into something's actually going on at the hip. And so very often in our office, if they come in for knee pain, we always check the hip first. And if when we're examining the hip, they're complaining of their knee pain, we always get a hip x-ray as well to look for this or to rule this out. Because they may not even complain of hip pain. Most of the time they do, but sometimes they don't. So just put that on your radar to keep in your mind. But if you do see them, put them on crutches, say no weight bearing, because this can go from a walking stable injury to a very unstable injury with very minimal trauma, because it is a growth plate injury. It can be acute, it can be chronic, and so we want to keep them off it to protect that growth plate and the blood supply to the hip for as long as we can. So these are, in my practice, they're skateboarders. And so a skateboarder kind of rolled his ankle, and you can see the base of the fifth metatarsal fracture right there. This one has a wide range of treatments. The simplest is a short leg splint, give them crutches. You can put them into a walking boot, you can put them into a post-op shoe, all of which are fine. But we're sticking with the theme of the splints. So this kid dropped a weight on their foot, a couple oblique fractures of the third and fourth metatarsal shafts, short leg splint, give them crutches, encourage them to get a knee scooter, ask around your church, your neighborhood, your family, your friends. Somebody probably has one sitting in a closet that's not being used. Insurance does pay for them, but they make you rent them for 2 months, which is over $200, or you can buy them on Amazon for $120. So I always tell them buy them. And so again, sugar tongue splint, not perfectly placed, follow up in a few days, follow up this week, 3 to 5 days. Another base of the fifth metatarsal fracture. Now we're into the sports stuff, okay. And so we're going to go through a few sports cases. So kid comes in, and so these are some warning signs of athlete who needs further workup on their knee. And so if they come in complaining of they had an acute injury that led to swelling, not puffiness swelling. So when somebody says they have swelling on their knee, it's very important to differentiate, is it puffiness or is it water on the knee? Okay. Puffiness is the type of swelling that like comes and goes. They kind of try to convince themselves that there's something there. It's typically a chronic problem. The 13 to 15-year-old adolescent females, hurts going up and down stairs, right? Like that's a different problem. But if they had an acute injury, got water on the knee that stayed for a few days, heard a pop, felt a pop, heard a shift, felt a shift, those are concerning symptoms that even before you examine them, you know they're going to need an MRI. Okay, and so that you're already going down that pathway. But to do that, obviously start off with an exam, try to figure out what the problem is an ACL, meniscus, patella. Get an x-ray if you have the ability to. And then when you look at this x-ray, you can see a avulsion fracture off of the lateral tibial plateau. That's called a Sagan sign or a Sagan fracture. And so the lateral capsule of the knee tore off. That happens when the knee twists and pivots, which is very common with ACL injuries. And so you should kind of know that that's already going on. Would you click the video? I love these videos, you guys might not. Working beautifully. While we're trying to get that up and running, because we literally had it before I started, bummer. Any questions up to this point?
So, just like with the mid-shaft humerus fracture and like that, just to clarify, if there's neuro involvement, that would be sooner follow-up, correct?
So when there's neurovascular injury, right? And so the easy way to check for neurologic problems: rock, paper, scissors, A-OK. That's everything going down to the hand. In the kids' world, that's super easy to remember. Obviously, check the radial pulses, the hand sensate. If it's not a penetrating injury and it's not an open injury, it's not a problem, right? And so the incidence of true neurovascular injury in all of the injuries that I showed you, as long as it's not open, non-penetrating, it's a bruise, it's a neuropraxia, or it's apprehension and they're not gonna do it because it hurts, right? And so every child who comes in with a both bone forearm fracture has a neuropraxia of the median nerve because they're like this. Straighten out your fingers, I can't. No, you can. It's you don't want to, because doing this moves the tendons across the fractures, which is really painful. And so that's a really important distinction. And so I think you should take heed in the fact of definitely document what you see, and that's real, and that's something that needs to be followed up on. But as long as it's non-penetrating, not open, if it is a nerve injury, it's a bruise, which will get better, right? But if it's open or penetrating, then obviously that needs to go to your next level of care, go to the ER, because that does need further workup, or a crazy displaced supracondylar, which I didn't show you any of those, but those go to the ER because those need emergent surgery. Any other questions?
What are you using for pain control in these cases?
Tylenol and ibuprofen. And so so in Florida, we have a law that you cannot prescribe medicines unless you see them. And if you are going to prescribe medicines, if you see them, you can only prescribe 3 days worth. That's it, no matter what. Posterior spinal fusions, 3 days. You can apply to give for 7 days, but increasing studies have shown that we're transitioning away from all narcotics, period, for a lot of our surgeries. And so Tylenol and ibuprofen, if they say, can I have a narcotic? I say only if you have surgery. Any other questions? And once they're immobilized, they feel a lot better. They really do. They're screaming in agony, but once they're in their splint, it's like the world changes. Anything else I can answer? Were we able to get that video running? If not, I can go on to the next case. It's no big deal. We were worried about getting the video to work, but the audio works. That's good.
Can I ask you a question?
Yes.
So if the biggest fear is like you have vascular compromise, so kid comes in, they got a horrible fracture, it's not a penetrating injury, it's not, open, but we are having trouble finding like a radial pulse or, distal pulse. At what point is it beneficial for us to call you and try to reset it, or fix it, or is it just like an immediate emergency room, and will they be okay at that?
Send them straight to the ER. You know, so always when in doubt, send them to the ER, right? If you're in urgent care and it looks horrible, send it to the ER because they can do all of the workups. And so the incidence of vascular injuries in both bone forearm fractures is like not open, not penetrating is like nil. The ones that in the peds world that you worry about neurovascular injuries are a true knee dislocation, like the knee dislocates, right? Those all almost notoriously get either an ankle brachial index, which is done in the ER, or a CT angiogram, which is done in the ER. And the same thing with supracondylar humerus fractures, ones that are horribly displaced, hanging out the backside of the arms, crazy deformed. Those go to the ER anyway, right? But both bone and firm fractures, even if they are horribly displaced, the incidence of a vascular injury that's going to lead to life complications is almost unheard of in the peds world. And so there's lots of reasons for why they couldn't, but if it's horribly displaced, it's just pass it on. Splint them, right? Splint them like we talked about, but then pass it on. And so the reason I want to talk about like ACLs is there's a lot of changes actually going on in ACL literature and in research. And so in orthopedics, not much changes over time. We just kind of like rinse and repeat what we did 30 years ago, find out it doesn't work again, and move on from it. Yes. And so the ACL injuries, there's a couple of different types. There's contact, there's non-contact. Yeah, go ahead and you can start the video. And so these are all videos showing how the ACL actually gets hurt. And they'll zoom in right there, right? And so it's not much. It's that land, it's that pivot, it's that slight valgus moment of the knee, and it just slides. And so it doesn't ever look like much until you like really zoom in, hone in on his knee, and it's right there. Right? And so plants, pivots, brings that knee in, and it just slides out. These people will complain of water on the knee right there. It's huge effusion the next day because there is an artery that goes to the ACL, and so it bleeds. What you'll notice about this person right there is he's wearing an ACL brace when it happens, right? And so braces, not that they don't work, but they're not perfect. And see, the only way to really control the rotation right there, boom. And so the ACL is responsible for translation and rotation of the knee, that pivot shift type mechanism. They'll have water on the knee that'll last 3 to 5 days, not puffiness, like it's massive. These patients need an x-ray and they need an MRI because the ACL is responsible for the stability of their knee. The most dangerous person is the young athlete who's 3 or 4 weeks out from an injury like this because they feel back to normal. Because to be a physician, to be a teacher, to go to school, to be a student, you don't need an ACL to walk on a daily basis. And by weeks 3 or 4 after the injury, they feel normal again. And in some places, I'll meet people who are 6 months out from an ACL injury that are back to playing sports and back to doing all these kinds of things. But when you inquire about the initial injury, you're like, man, you tore your ACL. And you ask him like, hey, how is it when you play sports? How is it when you cut? He's like, oh, my knee gives out and shifts like every time. It's like, oh my gosh, it's terrible. But to walk, you don't need it. And so it's very important to drive those people home. And if you have those concerning symptoms, that large effusion, that feeling of a pop, get them an MRI or get them to the place where they're going to get them worked up. That's not the typical anterior knee pain where you're going to send them to therapy and see how they do. All right, I can go to the next slide. And so if they do show up like that, knee immobilizer and crutches, and then follow up in a week. You guys see this all the time. So volleyball players, soccer players, football players, basketball players, they jump, they land, they roll their ankle. Some of them will have done it hundreds of times. They say they have weak ankles, right? And so when you go through your Ottawa ankle rules, see if you need an x-ray. The reality is you're getting an x-ray. If not, you're sending them to someone to get an x-ray, because if not, then they're going to go to someone else to get an x-ray. But once you find out the bone is not broken, you put them in either a lace-up ankle brace, an air cast, a walking boot, give them crutches. As long as it's not broken or fractured, yes, they can put weight on it as they feel comfortable. The challenge with ankle sprains is the long-term proprioceptive loss. And so we all grew up with, well, I roll my ankle, and then you roll it all the time because you lose the spatial awareness of your foot. And it's not a lot. It's not like your foot's going to be way over here. But by just a few millimeters landing wrong, you're going to roll it again, roll it again, roll it again. So all of those athletes, typically basketball players who are like, I have weak ankles, no, you just rolled it once really badly and never retrain the foot and the ankle to get back to where it needs to be so that you don't do that. And so anybody who comes into our office with an ankle sprain, they go into either an air cast or a lace-up ankle brace. I like lace-up ankle braces because I'm a fan of motion, and you can play with it on, and they all get therapy to undo the imbalances that happened with the injury, the BOSU ball training, standing on one foot, throwing it back and forward, jump stances, landing, so that it doesn't become a problem. Because if they continue to roll their ankle, they're going to develop cartilage problems, arthritis, they're going to break something, or they're not going to be able to get back to play and have to have surgery. And so McDavid is a very popular ankle brace, crutches, yes, they can put weight on it, follow up in a week. This is your football player. Football player runs into somebody. Where I'm from, they say, you know they have it when they say they sprung their shoulder. Oh, doc, it's sprung. I'm like, oh, okay, you let it loose. It's free. But, right? And so AC separation, shoulder separation, same thing, simple sling. You know, even though it looks like it's off in outer space, it's a type 3. That's going to heal on its own and do fine. Super arguable. Yes, you can do surgery on that. Will also do fine. And so these are typically non-op as long as it's inside and not inside the trapezius. And so follow up in a week. I wish I'd zoomed out on this. This was my patient on Tuesday. And so this is a knee. And so you can see the kneecap is dislocated. And so the challenge for these kids is you'll see them acutely and they're like this. And all they need to do is straighten out that leg and it'll pop back in, right? Because the patella engages the trochlea and becomes bony stability at 20 to 30 degrees. But their kneecap's hanging out to the side, so there's no way they're going to move their knee because that's going to be horrible. And so the best thing you can do is like distract them with God knows what, and then straighten their knee and it'll pop right back in. But the challenge with these is that they have a 50% recurrence rate. Super, super high. And so from the pediatric perspective, I do a lot of surgeries for these. No, they don't all need surgery. It's based on a lot of anatomy factors, but yes, they definitely need follow-up. And so if they're in your ER or in your urgent care, get them put back into place. The easiest thing is straighten out that knee. And if you straighten out the knee and it doesn't pop back in, it takes like one finger just to give it a little encouragement to go back to its home. And then you put them in a knee immobilizer, give them crutches. Yes, they can put weight on their leg as they feel comfortable. But when they come and see us, we are evaluating for them for cartilage lesions, how many times have they dislocated, as well as risk factors for dislocations, because the redislocation rate ranges from 40% for someone who is first-time traumatic, has no real risk factors, and they'll do fine with therapy and a brace, to those who are 80%, where they have like every risk factor possible to have this happen again. And the big problem with these is, yes, your kneecap dislocating is an issue, but every time that happens, you can break off a piece of cartilage or bone, and from a surgeon perspective, you know, that's arthritis. We're not great at fixing broken cartilage. The outcomes of that aren't awesome, but we're really good at making your kneecap stable. So if you have a child with patella instability, patella dislocations, get them reduced, get them into an immobilizer and crutches, and get them to see orthopedic so we can evaluate them. Do they need surgery so that this doesn't become a long-term problem? That's it. We made it through. Any other questions?
I have another question. Do you have any recommendations when patients want like osteobioflex or glucosamine chondroitin? I'm sure you hear that a lot about.
A lot, yeah.
Arthritis
And so let's talk from the fracture perspective, right? Like, so how can I help my fracture heal more quickly? You can't, right? There's no supplement you can give that's going to make them heal in 4 weeks versus 6 weeks. So it's fine. But If they have fractured more than 2 or 3 times, there is literature to show that if you supplement vitamin D, it reduces their subsequent fracture risk. And so if they ask me that question, it's always, there's nothing you can do now, but if you talk to your PCP, your pediatrician, your primary care, get what the recommendation is for the vitamin D supplement based on your age group, because that can reduce your risk of breaking again. The glucosamine, chondroitin, and sulfate, that's a big question on my ACL patients. Because once you tear your ACL, you're at a 75-ish% chance of arthritis within 14 years. When you're 35, 40 and you tear your ACL, that's a very different conversation versus like the 7, 8, 9, 10, 12-year-olds that I'm taking care of. And so I do encourage them to take glucosamine, chondroitin, and sulfate. No, it's not going to undo damage, and if you have arthritis, it's not going to like regenerate cartilage, but it is a vitamin supplementation for the joint, which can help long term. There's also some newer technology on the market of how we treat ACLs that we're hopefully for the younger athletes will help prevent arthritis.
Thank you. Oh, another question.
Do you have a comment on knees over toes guy?
Knees over toes, yeah. And so ACLs have increased 2% per year for about 20 or 30 years. In the 70s, there's a published literature saying ACL tear is not possible in growing children because it's just not possible. The youngest ACL I've heard of is 3 years old. The youngest ACL surgery that I've performed is 6 years old. Trampolines. In young, I love trampolines. I think they're wonderful. They also pay for my lights. So I encourage everybody to get a trampoline. I go to trampoline parks and drop cards accidentally all over the place. I've invested in several. No. But so ACL prevention programs are proven to work. They cost money, and insurance doesn't pay for it. And the reality is the majority of ACL tears that you see are not necessarily in affluent populations and don't have access to it. And so anybody that comes in for adolescent knee pain where I identify some risk factors for ACL, every female soccer program should be doing FIFA 11, which is just like a warm-up to prevent ACL injuries. Strings and prevent ACL is proven to work. There are programs around the country that you can sign up and go do it, but it's hard to get people to buy in to preventatively doing something that is never going to happen to them, right? And so it's always an afterthought.
Have you had any experience with prolonged alendronate use and then hip fractures? So they asked us to back off on more than like 5 years of prescribing of that.
So in the adult world, yes. And so the problem is the bone's not remodeling. And so your bones respond to stress. And so if you don't move them, you lose them. And for patients of ours who have been in a cast for a long period of time or not walking for a long period of time, you can tell on x-ray that they can't because they are very osteopenic, osteoporotic, and they have halos as shells of bone. And so you have to get them to walk. The problem with those medicines is they're designed to build bone, which is great, but bones also need to break down and remodel, and they don't allow for that. And so they become very torsionally weak unless you allow them to remodel, and that's the reason for that. Because bones are really awesome in flexing, bending, but just like a cement brick, like you can try to twist it and do anything, but if you drop it on the ground, it shatters, and you're like, that didn't take much. The same thing with those types of hip fractures. And that's a catch-22, right? Like you're trying to prevent one problem, but you're causing another.
Any other questions? All right. Thank you so much.